Good afternoon, everyone, or good morning or evening, wherever you may be. I'd like to welcome you to this webinar on community rights and gender, meaningful engagement with African-centered masculinities to end TB. This is a webinar hosted by the LIGHT Consortium, Shift TB, and the Union Working Group on Gender Equity in TB. My name is Catherine Horton. I'm an assistant professor at the London School of Hygiene and Tropical Medicine, where much of my research focuses on gender and TB, and I also co-chair the Union Working Group on Gender Equity in TB. The global TB community is united and calls for an equitable, gender-responsive, rights-based approach to end TB. However, progress and achievements are lagging. In many settings, especially in African contexts, men are disproportionately affected by TB disease and face systematic barriers to accessing TB prevention and care that, if they were accessible, could improve individual health, reduce impact across communities, and accelerate progress towards ending TB by preventing onward transmission. Given these gender disparities, successful community rights and gender approaches to end TB need to be informed by theoretical and methodological frameworks that reflect the diverse and complex realities of affected communities. Today's webinar aims to bring together TB advocates, academics, and practitioners to elaborate African perspectives on a person-centered TB response, engaging men. We aim to advance understandings and visibility of African-centered masculinity theories and their applications to TB research, policy, and practice. To learn from advocacy and research that center the lived experiences of African men affected by TB, and to explore ways forward for an equitable, gender-responsive, rights-based TB response that engages men in African contexts. To those ends, we have a fantastic panel of speakers today who bring lived experience and expertise from perspectives of advocacy, research, and practice. And I'm very much looking forward to learning from their perspectives. Our session today will consist of 4 speakers with interludes between each, followed by time for questions and discussions. A few notes before our speakers begin. Joy, if you could share our housekeeping slide, please. Just to make sure everyone's aware, your microphones and cameras have been disabled just to minimize the risk of network disruptions during the webinar. But we do ask that you would use the chat to introduce yourself. Please let us know your name, an organization you may be from, and where you're located, so we can all get a sense of who's joined today. We'll also have time at the end of the webinar for any questions and for discussion. So we invite you to submit questions for the speakers throughout the webinar using the Q&A function. You're welcome to submit a general question for the full panel, or if your question is for a specific speaker, please do include their name when you submit your question. And finally, just a reminder that words matter, and the language that we use influences stigma, beliefs, and behaviors. So we ask that you please use non-stigmatizing language as recommended by the Stop TB Partnership's Words Matter Guide in your questions and comments. I think that's all of our housekeeping notes. So it's my pleasure to now introduce our first speaker. Goodman Makanda joins us today from Cape Town, South Africa. He is a survivor of drug-resistant TB and a passionate TB activist who wants his TB journey to inspire others. He's an advocacy officer at TB Proof and usually holds talks together with Phumeza Tisile, who's a member of the LIGHT Consortium's External Consortium Advisory Group. We're grateful to have Goodman with us today to share his perspective of lived experience and advocacy. Welcome, Goodman. I'll turn it over to you.
Thank you very much, Che. As you already mentioned, or you said, my name is Goodman Makanda, based in South Africa at the Western Cape. Ex-RTP survivor that living with one lung, and I like the topic that we are talking about today. It's very encouraging, and it needs to disseminate it to the community, to the people that they have been affected. As a man, now I will speak on my own perspective as a man, and what happened. How did I find out I do have a TB? Where did I go first? As a man in South Africa or in Africa, if you are the man that's seeking help too much at a healthcare facility, the community discriminates you as a man, not so you're supposed to go to the clinic. Because if you keep on going to the clinic, you will look like a weak person. I will reflect back to my story. When I was diagnosed with TB, I vomited blood while I was coming from work. And then at the back of my mind, it's nothing to say I must go to the clinic, but I prefer to go to the private doctor so no one will see me. But unfortunately, the doctor sent me back to the healthcare facility where I should be tested for TB. It's when the stigma started, because now you should be going on that time to the clinic every day to get the injection, because I was infected with the XDR-TB. So it was a challenge even to go to the clinic. I must answer questions that it leads men to stop taking the treatment, that it leads men to die a lot because of the stigma that happening in the community. If we can compare a man with women, the women, they are flocking into the healthcare facility, but you will find out less men, they are not. Two, it's because of our room services. They've been written some of the chronic illness that we don't want to be associated with. Like, I'm a man that living with diabetes. I do want to be associated to the room so everybody will know me, I'm having a diabetes. I would rather go to buy it in the private hospital or private doctor. So it's really a challenge. I don't know how can we work together to do what you call one-stop shop where everything will be happening. No matter you are HIV positive, you're having TB, you're having diabetic, not to be discriminated, go to the room 4 where you will be getting the medication for tuberculosis. That's why you will find out men, they came in to be tested positive. After that, they disappear to go to another clinic because of our design of our healthcare system. And we're having a problem when it comes to, and a person will be asking me, why you became an advocate, why you became an activist. I learned from the HIV because I see the problem is there when it became to our healthcare system. It needs to be fixed. It needs someone that can come through and say, this is not right. That's why I joined TB Proof to advocating for better treatment, for better services. Even I was not admitted in any hospital because we were discriminated. When you're having a DRTB, you should be admitted to the outside hospital, that you will be far away from your family. They can't even visit you. So as a man, I think from the whole of this in South Africa, I'm the man that advocating for better medication, because it was worried me. What if I getting sick again? And then I will go to that broken healthcare system. So let me fix things now. Let me cry out now about it, all of these things happening. So I'm working at TB Proof now to deal with some of the patients that I can see. Some of the men, they hesitate to come and get tested because of the discrimination, because of the worry, what is they going to say people when they see me in the TB room. So as we're standing here together, I hope other speakers, they will be speaking accordingly on what we think we need to resolve the problem. Thank you very much for your time.
Goodman, thank you. Thank you so much for sharing your experience with us, for your honesty and your advocacy and your continued support of other people and other men affected by TB. Thanks a lot for joining us today. We've included brief interludes today between our speakers to bring community rights and gender approaches to life as we transition from one talk to the next. Our first interlude comes from the UN multi-stakeholder meetings that took place in New York earlier this year in preparation for the UN high-level meetings, including on TB, that will take place in September. One thing that stood out was the unity among TB survivors and advocates in their call for an equitable, inclusive, gender-sensitive, rights-based, and people-centered TB response. Since most of us may not have been in New York, let's see them in action during the Yes We Can End TB March.
NTB! Yes, we can! NTB! 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 Yeah, we can! NTB! Yeah, we can! NTB! 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 Yeah, we can!
Thanks, Tagreed, for sharing that video with us. I think that energy is really, really palpable there. And I hope it continues in the lead up to the high-level meeting. I would now like to welcome Dr. Ayman Ashaba Muwine, who is a lecturer of critical studies of men and masculinities in the School of Women and Gender Studies at Makerere University in Uganda. He holds a PhD in sociology from Stellenbosch University, and his current research involves an archival study on men, marriage, and memory in Uganda, and the IDS-led Countering Backlash, Reclaiming Gender Justice program. Today, he will introduce us to African-centered masculinity theories relevant to TB. Welcome, Ayman. The floor is yours.
Thank you so much, Chair, and thank you those who have spoken before me. I have been introduced, so I'm going to straight into the talk. If you can go to the next slide. I am looking at African-centered theories of masculinity. And in this conversation, I will largely pick up a few concepts and theories of masculinity. I will look at briefly on the body of knowledge on masculinities on the African continent. And I will make an attempt to look at how masculinities can influence infections around TB. This is a definition which I wanted to press there. I know there are diverse definitions of masculinities, but the core message in this definition is that we often look at masculinities not as one, but different forms of masculinities. And we refer to them as social practices or cultural representations associated with being a man within particular cultural contexts and also times and spaces. If you can go to the next. Note that the growth of masculinities research on the African continent is not different from the rest of the rest of the world. You will find that the primary theories around masculinities were suggested by Robert Cornell in the seminal work on hegemonic masculinity, when Cornell attempts to look at how men are not that universal as other sociological theories had seen before. And in this theory of hegemonic masculinity, it does indicate how there are certain values, norms, and expectations that are associated with being a man that hold a dominant position in society. Those that majority of the men aspire to, even when not all of them fit into that set of expectations. And so this kind of dominant category of masculinity, Cornell argues, is characterized by domination of heterosexuality, physical strength, aggression, suppression of emotions, ownership of resources, and being key critical decision makers. And then, you know, he goes ahead to argue that below that category of the dominant form of masculinity are other forms of male behaviors which do not fit into that dominant ideal image. And so those include men who may not fit into the ideal, but nonetheless, they do not critique or they are not challenging that dominant position, but also men who fall into margins of society in great need, as well as those who are in subordinate positions. And so that kind of theorization opened the way to look at how men can be different in different societies, how men can be products of social environment, but also how we can have hierarchies amongst men as a group. That you have those who are powerful and dominant and privileged, and then you will have other categories of men who do not necessarily fit into that ideal dominant image. And we have since moved from that to look at theories that fall into the broader category called critical masculinity theories. And these are largely about acknowledging men as gendered beings and as being products of social environments. And so in this next slide that has been shared, we look at the broad literature that is on the continent that has shaped the understanding of who men are on the African continent. I will pick a few of them because the first two come from the global platform, Cornell, Theorizing Masculinities. But from then, we have Bell Hooks, you have Kopano Ratere from South Africa, you have a group of South African researchers looking at how masculinities are so specific and produced within particular cultural contexts. And then the next set, I picked one of the decolonial feminists, Sylvia Tamale, who particularly enables us to think of Africanness and African identity, explaining why we need to think of African identities, including African masculinity. If we go next, then we have seen that we can every talk about African masculinities. And the question I posed as we go on is whether we can speak of African masculinities without being accused of being essentialist. But Sylvia Tamale does, gives us nice ground on how to argue this and says that if you look at Africa, it occupies a unique position, that its relationship to the transatlantic slave trade, colonialism, and imperialism is so unique, and its structural legacies run so deep that it would be foolhardy or even dangerous to gloss over these in any analysis of the position that Africa occupies in the global politics of knowledge production. And so she argues that any kind of scholarship, masculinities, femininities, needs to pay attention to the difficult histories of colonialism and the legacies that Africa has gone through, because these have shaped gendered identities the way we have come to know them right now. And she picks up one of the key uniqueness of African cultures, using the concept of Ubuntu and saying that when you look at African traditional ideologies around justice and fairness, the philosophies of humanness and communitarianism, and when you look at solidarity and interdependence amongst men and women, you tend to feel that, yes, we can speak of African identities, in particular, African masculinities. And so in the next slide, then I look at the kind of masculinities that we can talk of on the African continent, and the kind of context that produce these identities. Kopano Ratere, who is a professor in South Africa, writing about masculinities, notes that African masculinities and men do not grow naturally from the ground. They are products of the interactions between men and women and the kind of the cultural histories that have gone through, the kind of culture and social cultural uniqueness that African communities find themselves in as a result of intersections of class, of ethnicity, of religion, of sexuality, and in other cases of seniority that when you look at a man in an African community, what makes him one might be a product of an intersection of all these social identities. And so as we go into the next, we particularly wanted to highlight, for instance, how colonial history produced certain forms of masculinities according to Sylvia Tamari. She looks at how colonialism shaped gender relations, especially when it produces men and women as polar opposites. And she looks at where, looking at the British colonial rule in Uganda, she notes that where there had been a broad distinction between the public and private in Uganda, the British structures and policies focused on delineating a clear distinction, guided by an ideology that perceived men as public actors and women as private performers. And from that kind of literature, then you get a set of masculinities that you can define as colonial masculinities, in which men are produced as public figures, income earners, decision makers, and very controlling, and then women as the other. And within that, you get versions of men and masculinities around, men as breadwinners, men as aggressive and strong, and non-vulnerable. When you listen to Goodman and the experiences that he was talking about, these are contexts of expectations of men as non-vulnerable. You're not expected to be in the hospital. And so when you come, a medical discourse does not know how to deal with a man who is not identifying as strong and aggressive. And then the other category of masculinities is described by Ratteri as heterosexual, patriarchal, capitalist masculinity, which is dominant in Southern Africa, but in other parts of Africa, and that this kind of masculinity is characterized by domination, including sexual domination, controlling behavior, decision-making, resource ownership, the feeling of being like a warrior, and also taking risk. And that men who do not conform to that are actually seen as not men enough. And so when infections like TB come in, and you want to genuinely express that weakness of being ill, you're not seen as a man in that sense. And in the next slide, I also wanted to briefly highlight how these kind of histories have led to what feminists, but also masculine scholars have characterized as ethnographic moment in masculinities on the African continent. And in this, they are talking about an emerging scholarship that is characterized by a lot of research documenting experiences of men in their diversity, documenting the interplay between different forms of male behavior, and also looking at how these are produced in different social cultural contexts. For instance, we've had research around masculinities and health that is looking at men and HIV, that is looking at men, the place of men in gender-based violence, that is looking at sexual and gender-based violence. And in these studies, you tend to get a general argument that is looking at how masculinity norms, practices, and beliefs influence negative health outcomes. And we have also had studies which look at how men who conform to traditional forms of African masculinities lead to, negative health outcomes. For instance, men who are seen as breadwinners and providers, who will tell you they are too preoccupied with that role of provisioning, preoccupied to seek for medical health care. Or men who see themselves as warrior-like, risk takers, and non-vulnerable, and therefore that influencing their health-seeking behavior. We've seen Lindsay Close, who is at the University of Western Cape, theorizing how conceptualizing masculinity as non-vulnerable has greater impact on men's access to health care. I have also been part of a study that looks at how men greatly deny pain and resort to pain killing in the name of conforming to ideal forms of masculinity. And so you realize that these traditional behaviors of being a man have greater implications on the health outcomes that we deal with. So as we wind up, I want to share with you how we might link this kind of body of knowledge to TB as an infection. And you will agree with me that in some African contexts, when you observe TB wards in hospitals, one would easily say that TB looks like a man's disease. Yes, it is an airborne disease. It's an infection that spreads when you stay in contact for longer, if there is a source. But you will realize that those behaviors of staying longer and congregating, and they are actually closer to acceptable ways of being an ideal man. If you look at the risk factors for contracting TB, there is a correlation with some of the culturally accepted ways of being a man. The gathering for a long time, for instance, in sports activities, in playgrounds, in betting, in drinking, and all these lifestyles which are seen as normal and acceptable, they actually might increase the risk if there is a source of an infection amongst men. The HIV and AIDS, which is another recorded risk factor for TB, it has its own masculine perspective. If you look at multiple sexual partnerships as manly, or even denying pain. I've seen cases where men are saying, well, I know I'm getting weak, but how do you expect me as a household head to line up with children and women for septrin at a health center? So in a way, the stronger, resilient norms around being a man weigh heavier on the lives of men and compromise their access to health. And of course, other lifestyles like smoking and alcohol might also increase the risk to TB. And one of these, in one of these, as I was doing this, I had an opportunity to share with a doctor, medical doctor, who actually deals with lung diseases. And I was asking him, is there any relationship between masculinities and TB? And he said, well, yes, it is an airborne disease, but it tends to spread when people meet for longer, when they meet and stay longer. And he said, so men's social behavior make TB spread a little easier. And he talked of when men meet in bars and betting houses and in marriage joints, and when they tend to stay longer. And that makes them prone. And also that they will tend to come later in the hospital when they have created enough space to spread the infection. And so, these are some of the things that we can look at in terms of how masculinities can actually increase the risk to the spread of HIV, of TB. Thank you. And these are the last point in terms of where do we go? What do we think about? And that is particularly to say that you get to realize that some of the culturally celebrated male behavior and lifestyles, they predispose men to TB. And that means then we need to be deliberate in terms of understanding men and their behaviors as gendered and as products of varying social environments, and how these actually influence our health outcomes that we are working on. Thank you.
Thank you, Eamon, for a really insightful presentation and for your patience at the beginning with the technical difficulties. I'll just remind our participants that if you do have questions or there's points that you want to discuss later, please do enter those in the Q&A. And we'll now move into our next interlude, which is a song created for the Tupumui study. This study was led by the Liverpool School of Tropical Medicine in the UK and assessed the rate of lung disease among children in Nairobi, Kenya. The song is called Pumua Fiti Ishi Fiti, which means live well, breathe well. It was written and performed by the pardon me, Tupumue music crew and lung health champions from the 2 study communities to create awareness about the study and about lung health. Enjoy.
It's MOD on the beat.
Wasafi maisha marefu. Tupumue wasafi maisha marefu.
Pumua fiti, ishi fiti, maisha fiti na riziki. Lung problem imekuwa ngori na hakuna mtu wa kututoa kwa bori. Labda Holy Spirit atutoe kwa ngori ili tuishi hii maisha bila bori. Pumua fiti, ishi fiti, pumua fiti, ishi fiti.
Pumua fiti, ishi fiti, maisha bora wazee kwa vijana. Pumua hewa safi, fanya kazi kwa bidii, wazee kwa vijana. Pumue hewa safi, maisha marefu. Pumue hewa safi, maisha marefu.
Come on, let's join hands too. Down all these NCDs. Come on, let's join hands too. Decrease this immortality rate. Pumua fiti, ishi fiti, maisha fiti, 50-50. This a wake up call, don't get comfortable. This a matter of us and sit down around table. Tunataka tujue nini mbaya na lanza Mwafrika. Watoto wanakufa wakiwa wayanga. Big up against problem ni come on, let's join hands too. Decrease this immortality rate. Come on, let's join hands too. Rambla all these NCDs.
Na nyumbani, barabarani, hata shuleni. Wazazi kwa watoto tujilinde.
Thanks, Sagri. Our next speaker is Dr. Jeremiah Chikavore, a senior research specialist at the Human Sciences Research Council in South Africa, with training in sociology and public health, and he's one of the founders of Shift TB. His work applies social science approaches and African-centered complexity and intersectionality lenses to a range of health issues. His areas of expertise include masculinity, gender and youth, healthcare access and care-seeking behaviors, and TB and HIV. His presentation today is titled Centering Experiences of African Men with TB and draws on his research with young men in Southern Africa. Welcome, Jeremiah.
Thank you, Catherine, and greetings to the audience. I hope you can hear me well.
We can, yes, thanks.
Thank you. So thank you, Catherine, and the organizers for this opportunity and speaking after very exciting presenters. Thank you also to my fellow panelists. Very interesting insights that came through there, and the performers were wonderful too. So if we go to the next slide, Joy. So we're already learning. Yes.
Would you be able to put your camera on? Sorry.
Oh, okay. Let me do
Only
that.
if you're comfortable. Thanks.
Okay. Is that okay?
Perfect. Thank you.
So we have already learned from our previous speakers that gender is a social construct and that it is relational and involves relations and situated interactions of men, women, and non-binary individuals as they relate within and across their subgroups. The form and influence of gender on various aspects of our lives is increasingly understood, but it is also highly complex, as we've already heard from the previous speakers. And thus, also has a lot that needs ongoing discussion and exploration, especially because it works in intersection with all the other characteristics and factors that are defining the life and position of any individual. If we go to the next slide, Joy. So the message regarding some of the key indicators for TB continues to highlight that there certainly is an issue of concern with respect to men and the male sex. And I will emphasize two, because this is within the limits of the absence of gender, non-binary individuals within the conversations. We are aware that they are poorly represented within the tuberculosis epidemiological profile, but also within the limits that we understand the topical and critical conversations regarding women as on structural and intersectional vulnerabilities. So these are all issues that are tied together, but men relate among themselves across ages, across class, and with women across ages, across class, and all the other various identifiers. So this slide is just to highlight the importance of also focusing on men because they have specific tuberculosis profiles. But not to dwell on this, as this is the focus of today's panel. As Catherine said, I will turn my attention more towards how to center men and African masculinities within the tuberculosis response. Next slide, please, Joy. So within the TB cascade, from exposure through the healthcare seeking and access process to the treatment outcome, we can pay attention to some of the steps and what data, including qualitative research that we have been involved in, points to. We know that more men than women spend significant time in poorly ventilated socializing and working spaces, as we have heard from our previous speakers. And furthermore, men have higher alcohol and substance use rates. Men were also found to be more efficient sources of household transmission in a study that was carried out in Southern Africa. And their exposure and progression within disease and their propensity to spread are also related to their poor linkage to care. And men's poor linkage to care is seen across various conditions, including HIV and AIDS, and also their poor adherence. We found, for example, that men may knowingly or unconsciously opt to suppress their symptoms, and we've heard this already from the previous speakers, opting to work or instead to socialize and drink. And sometimes they argue that this helps to oust symptoms, to chase out symptoms. But also they're meeting their socially defined role when they choose to work, their socially defined role. And as we have heard, this role is constructed, has been a product of historical factors over time. And many men now define themselves, even though they find challenges in executing this role, they define themselves as providers. Or men may simply do all these things to give the facade of being invincible. Again, we heard this before. When illness in men can be a stigma, and Goodman was saying exactly the same thing. How do you deal with that? You present a facade of being strong in order to get around being a source of public ridicule. Next slide, Joy. Again, this is something that has come up already. The structuring, the services, the healthcare services, are they working well? Are they meeting men's needs? The structuring, the staffing and operation of healthcare services does present a barrier for men when the opening times are not convenient for them, when there are not dedicated spaces for men, and they may feel they have to scramble for attention, scramble for places where healthcare services are already crowded. And when staff speak or perform routines in ways that can seem to be demeaning to men, Men may also face devaluation from being seen in the feminine or supposedly feminine healthcare spaces, or if they simply admit illness. And where unemployment is high and there is limited social protection, attending to healthcare can be costly for men and can mean opportunity costs. Alternatively, men can also choose to use their resources for family needs rather than for healthcare. And they might just not have the language to describe their symptoms or even downplay the symptoms and may choose to self-treat, which also interferes with diagnosis. And we are also aware in tuberculosis epidemiology that male sex has been associated with higher initial loss to follow up when men do not start treatment. And we also know that men generally have poorer outcomes. Next slide, Joy. So the public health approach, which puts emphasis on implementing the best available measures at scale and in cost-effective ways, has virtually guided the TB response in low and middle income countries. This approach was framed to address the HIV pandemic at the turn of the century and tagged the health sector to spearhead the response. And it relied on risk factor determination through surveillance, also stressing selecting the best in the responses that were available and implementing these in a way that would compensate for what were known already to be health care service shortcomings. But the primary also expectation was that it would help to implement it in cost-effective ways and reach as many people rapidly as possible. Now, this approach occurred in the face of inadequate funding support and amid health systems that were facing limited resources and staffing shortages. And this is despite the indication that the declines of TB in Europe in the 19th century also happened parallel to or due to improvements in social conditions. So while TB is already underfunded, the funding gap is likely to have implications for the support that is available to smaller scale exploratory studies that can illuminate social contexts more, and which can also shed insights and help to address the persistence of TB as a major killer. If we go to the next slide, Joy. So within this background, it is perhaps apt to reflect on attendant issues regarding tackling the question of men in TB in Africa as a gender issue, as a social science issue, as a local and also simultaneously global research and funding issue, but also as an equity issue covering issues of gender, of class, of race, the relationship between the global north and south, and so on. And this calls on us to reflect in critical ways on the concept of African men or African masculinities and the space within which we are having these conversations. For example, why are we focusing on African masculinities here and now? What is the problem as it is defined, or if many as they have been defined? Maybe who is active in defining these issues? Where are they geographically in terms of discipline? What are the assumptions that they bring in terms of method or otherwise? And are we approaching this as a scholarly field that we want to tackle within the tenets of equitable, just, and non-presumptuous engagement? How does the field sit within the global space, within the geopolitical, the geosocioeconomic terrain? So these are conversations I think that are critical when we want to locate and engage with African masculinities, particularly as they relate to health and more specifically to tuberculosis. Joy, if we go to the next slide. Now, it is there are issues that we also have to think about when we center African men and masculinities. Are we going to focus on men in the cosmological, philosophical way, centering Africanness in different ways that it is defined? Or are we going to apply a pragmatic approach where we look at men and their identities in contemporary and hybridized perspectives in the ways that men have been shaped? Yes, inclusive of the tradition, but also in terms of the current. Who are the men that we are dealing with today? We also need to recognize, as has been already highlighted, the diversity and contextualized nature and experiences of African men. But also we need to use methods, as Catherine highlighted earlier, that allow us to access men's experiences and allow also the parallel growth to social sciences in health alongside other disciplines. And it is very encouraging to learn that Makerere is also leading in that sense by engaging in masculinities. Congratulations to Makerere for putting that on the agenda. But you also need to pursue accents with broad social and health welfare. And yes, in health, we always talk about that. Everywhere we talk about health is social, but when we tend to putting this into action, we tend to limit to what is achievable in the short term and what is clear indicators. And I think this is the challenge that we need to work around. And towards my last slide, next slide, Joy. Of course, there's just the one before that. So there will be some potential challenges as well. The opposition to critical debate, we're seeing that around the world, but also how to reconcile women's gendered vulnerability with men's gendered health needs. Just to tie those two can also present challenges in terms of what to prioritize. Yet the fact that men should be a priority as well remains as we see. And also the reluctance to deal in terms of funding, but also in terms of policy with inputs and outcomes that can be amorphous or difficult to define or difficult to predict. So these are challenges that we'll need to work around and consider. I will stop here and over to you, Catherine. Thank you so much for the opportunity.
Thanks very much, Jeremiah. Great to hear from you and from your work. Our final interlude is a song called Arise and Stand Strong. It was written and performed by Nazim, a musician from the Gambia, as part of the Arise Hub. Arise is a research consortium also led by the Liverpool School of Tropical Medicine, working on accountability in urban health across Bangladesh, India, Kenya, and Sierra Leone. This song tells the story of the collaboration between researchers and the community, and its lyrics were inspired by their words about the joint research.
Thank you for these beautiful words. And the name of the song is called Arise and Stand Strong. So let's stand strong, all right? Let's go. We have a common vision for the sake of accountability, for a greater equity in informal settlement, leading the way through research and responsive action. Together we remain focused in our research, creating new knowledge across Bangladesh, India, Kenya, Sierra Leone, yeah, with Liverpool, Barassa. We will never walk alone, no, never walk alone, no, never walk alone, no, 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 never walk alone. Despite the pandemic, we arise and stand strong, bringing the voices of the poor to local and state agenda. Yeah, where challenges uncovered and reality revealed, restoring hope and trust for those living in their dreams. Together we remain focused in our research, creating new knowledge West Bangladesh, India, Kenya, Sierra Leone, yeah, with Liverpool by the side. We will never walk alone, no, no, never walk alone, no, no, never walk alone, no, 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 never walk alone.
Fantastic. We'll now move on to our final speaker today. This is Jeremiah Amoa Larbi. He's an accountant by profession, and since he survived TB in 2011, he's been involved in social mobilization and services for TB. Currently, he's the national coordinator at Ghana TB Voice Network and a member of the Ghana Country Coordinating Mechanism. He brings to the webinar a practice and programming perspective on community rights and gender. Welcome, Jerry.
Well, thank you very much, Catherine. And let me take this opportunity to greet everybody online. So as you said, my name is Jerry Amoa Larbi. I'm the National Coordinator for Ghana National TB Voice Network. But in touch basically also on leaving no one behind. That is a transforming gender pathway to health for TB as well. So next, Joy. All right, so this is going to be the outline of my presentation. We're going to look at who we are and what we do, what are the barriers to meaningful engagement with African masculinities to end TB. We look at that CRG assessment as part of it, and some recommendations based on our interventions in Ghana. Next. So who are we? Ghana TB Voice Network is a community of infected and affected persons with TB. Currently, we represent on the Ghana Country Coordinating Mechanism of the Global Fund, that is the CCM, and we have recruited and trained 124 cured TB clients as TB champions that conduct case finding and contact tracing in the community. Facilitate treatment, care, and support services for newly diagnosed TB clients. We also advocate for TB inclusivity in the policies and health service delivery in country, and also advocate for accountability and equity in accessing TB services within the country as well. Next. So what does the gender data from Ghana tell us? So this is the data from 2022 based on the work of the community TB champions, the cured TB patients that we have trained to find the cases in the community. This data clearly tells you that in terms of TB positive, male is almost 70% and the female is around 30%. If you look at the one on my extreme right, it talks about X-ray that are as a result indicate that are clinically diagnosed for TB client as well. It tells you about 73 out of it is male and 26 is female. This tells you clearly that even though there's a lot of catastrophic costs that also may incur in terms of assessing TB care and services as well. Next. So what are the barriers to meaningful male engagement in Africa? The Ghana National Prevalence Survey that was conducted in 2013 in Ghana clearly shows that the TB burden is very high amongst male than female. And this was also emphasized on the 2020, the Ghana Stigma Index study. This was the first ever stigma index study that was done in Ghana. And it shows clearly that stigma among male is 13.3, was higher compared to both female, which was 8.7, and transgender, which was 0.3% as it. This tells us that stigma is a big thing. And as of my previous speaker said, the main mention of stigma, which men faces in terms of accessing services. And also excessive alcohol use and smoking and also drug use predisposes men to a higher risk of TB infection. And other colleague Jeremiah said it in the slide, where men almost are at the sports, at the pub, always at the crowded places, enjoying themselves, whilst our women stay at home and taking care of the kids at home. So this moves me to the next one, that is the limited resources, that are unemployment and also poverty impede men access to TB health services, and also delay and the refusal to seek and engage in healthcare services. You know, men will always be men. They will always want to be strong, even though they are weak. At times, even though they feel they are very weak, they will pretend to be very strong to be there for the family, because they need to go and work and come and feed their family. So even though they show the symptoms of TB in terms of coughing, having some fever, they will still prefer to wake up early in the morning to go to work and also earn the living to come and support their family. Next. So how could we leverage on this to end TB? We basically have three intervention areas that I want to speak to here. We're looking at the cultural sensitivity around masculinity. We're also going to look at community engagement and gender transformative approach and fatherhood and family engagement. Basically, it is important that we look at the cultural values and beliefs and practices in shaping masculinity's identity. By understanding and respecting these cultural nuances, the intervention can be tailored to be culturally sensitive and very relevant in terms of the approach to help to engage African men effectively, as interventions are designed to align with their cultural norms, expectations, and also values. In terms of community engagement, it is very important that we leverage on the fostering community engagement by involving our local leaders. Most of our local leaders are men and also traditional healers and other influential male figures in the community. By engaging them in community-led initiative to promote ownership, participation, and also sustainability in terms of the solution to fight against TB. In terms of gender transformative approach, what are we looking at? We're also looking at the gender norms and stereotypes that may hinder TB prevention and diagnosis and treatment. So what do we need to do? By promoting positive and healthy masculinities in terms of encouraging men to actively participate in TB-related activities, such as supporting affected family members, and also challenging stigma that is associated with the disease. In terms of fatherhood and family engagement, it is the role of the father as a family head, to leverage the prospect to engaging men as a caregiver and also advocate for TB prevention and treatment within their family. Promoting men's involvement in TB-related decision-making and encouraging their support for treatment adherence can enhance the overall TB control effort to end TB. Next. So what are some of the recommendations? We're looking at to adopt a gendered approach to TB programming. Also prioritize early diagnosis and treatment for men with TB through integrated and patient-centered care. We also have to look at countries must also looking at conducting the patient cost survey. This to look at the extent to which to reduce the catastrophic costs that men incur in accessing healthcare services, by also providing sufficient enablers package for them. We also have to look at ensuring laws and policies that allow TB patients to take mandatory leave during the intensive treatment phase that should be enforced, because this is some of the gray areas where you need to, in terms of the intensive phase, you need to be at home for a month or even a month and 2 weeks to be able to go through this as part of the treatment cascade. So it is very important that as part of it, we look at this as a critical area where at least, even though the person is on leave, if it is enforced, it still earns a living to be able to still go ahead and take care of the family, which is very important. And also, last slide, to also look at specifically allocate funds to drive the integration of human rights and gender in the National Strategic Plan and of the Global Fund and the Stop TB Partnership grant applications that we also are looking at as well. So next. All right, thank you very much for your audience.
Thank you, Jerry. Very much appreciated. I'm sorry to rush you a bit at the end. I just want to make sure we have enough time for questions and discussion with everyone now. So if I could ask all the speakers to please switch on your cameras as we move into this time of questions and discussions. To our participants, please do add your questions using the Q&A function, and we'll answer as many as possible in the remaining time. And if you want to direct your question to a specific speaker, please include their name when you share your question. If I may kick things off with a question of my own, I have a question for Eamon. I'm really interested in what you see as being the areas of alignment between African-centered masculinity theories and those from other contexts, such as Connell in Australia and bell hooks in North America. And what do you see as the key differences in masculinities between these different contexts, and how are those relevant to TB research and practice?
Thank you for your question. We do see convergences in the sense that we are picking up from the idea of masculinities as social and culturally contextual. And that is a good beginning point. And Cornell will tell you that to be able to know that, you know, things can change, that men can change from this kind of belief that I am invulnerable to realize that I can be in a position of vulnerability. That's a great point towards social transformation. You don't want to look at male behavior as natural, as non-changing, which is one of those dominant ideologies that have crowded the gender conversation. So that is the interesting beginning point that we seem to share across these different geographic contexts. But the other uniqueness that you look at in the African context is the way how the work on masculinities has emerged from feminist discourse, and also the kind of emphasis that we do not need to look at men and women as polar opposites and always conflictual. But rather, as for instance, as Livia Tamari, who originates the concept of Ubuntu, argues, that there are many experiences in pre-colonial Africa where men and women dealt with things in a converging way, in an interdependent way, without necessarily looking at men on this side and women on the other. And so when you look at the theories around masculinity in Africa, you tend to see a theory that is picking up African pre-colonial interesting conversations on collegiality around men and women. And that is something that I have not yet noted into the kind of hegemonic class-based theorization from Australia and the US. But again, it could be because I have not closely engaged with it, but on the face of it, that is what I can see, that you're looking at critical masculinities from the likes of Kopano Ratere, Robert Morir, even when he's writing from African context, looking at how do we talk about men and women walking along each other to sort of avoid the tensions that we have seen in some contexts where feminism tends to come in contact with masculinities, and then the fear around if you engage with men's vulnerability, you're going to divert resources from the women's needs and interests. But if you look at, theorizing African masculinities critically by Kopano Ratere, he actually argues we need to bring men and women to walk alongside each other to realize that the struggles we are in are socially produced, whether it is in femininities or masculinities. And that, for me, that's an interesting perspective to negotiate, to move beyond, and to look at convergences that can enable us to talk about feminine weakness, feminine vulnerabilities alongside masculine vulnerabilities without either this or that.
Thanks. I think that's a fantastic point, looking at how all of these concepts and issues are interrelated. And I think that links very well to a question from Beata Ringwald from the Liverpool School, who was commenting on the fact that we've heard a lot about patriarchy and coloniality and how these affect men, but we know that these things also disadvantage women. And so perhaps the question to the full panel, how do you combine the focus on masculinity with the commitment to gender equality in your work, and perhaps more personally in your, in your broader life as a man more generally? Is there anyone who might address or comment on that question?
Oh, perhaps if you continue from that argument of what I started, you do realize that within critical masculinity studies, there is what we are now calling principles that guide male involvement in promoting gender equality. And these principles are emerging in the context of how do we promote critical studies of masculinities without reproducing male hegemony? How do we promote the focus on masculinities with the broader goal of promoting gender equality? And this has come, I've written about it. Lindsay Close from South Africa, at University of Western Cape has written about this, particularly on the question of what do men stand to gain from gender equality, so that we do not constitute and represent gender equality as something that has everything to benefit women and girls. So when you look at men as gendered and look at women as gendered, you look at them as subjects and products of social processes, and therefore likely to benefit from gender equality. And the key theoretical benefit that we have is the scholarship that is emerging, looking at critical masculinities, separating it from men's consciousness rising. That wave of scholarship that is looking at the reactionary nature of programs that look at male involvement, from a point of what about us? What about, us as men? Which sort of comes as a counterforce to feminism and gender equality. And again, Ratere will tell you, anything that works towards transforming and questioning patriarchy cannot be seen to reclaim men's perceived lost glory. We don't need to be going to that. We need to enable men to discover themselves, including discovering how they have been disadvantaged by patriarchy. And the moment we achieve that, then we are working towards a common goal of feminism and critical masculinities, working towards achieving gender equality. not feminism working towards achieving women's rights, and therefore men not being part of this conversation.
Thanks very much.
Yeah.
We have a question from Amang Joanna Ipoulet, who's a student of masculinities at Makerere University, who says, "Thank you, Goodman, for bravely sharing your experience with us. I would appreciate if you broke down those discriminations that men sick of TB face as they seek healthcare. Are they discriminations in terms of difficulty accessing services? Are the services expensive? Are they given only to a section of people? What exactly are these discriminations?" I know that Jeremiah and Jerry actually both commented on these issues in their presentations, but I wonder if you wanted to add anything or if there were particular points from the other talks that resonated with your own experience.
Yeah, I think Jeremiah also touched on this. We do really have a problem. One, we never been raised to be a weak person, to seek help outside. That is a cultural thing we should be talking about. How we can change their mind to accept the situation they are in. Secondly, is to stand on the queues in the healthcare facility. And I think I mentioned also the consulting room being written names on the door to say this room is belong to this such kind of community. That is the things that they are been pushing them away. Another thing is, I think, it's approach of our healthcare workers, because all of them are women. I'm not saying women are wrong to be, but we need to have some males that they can be. I can make example. I was doing an interview with someone as a male. He never disclosed to the counselor, but when we sitting together, the trust was built and then started to break down. And we not been used to break down in front of a woman. So some other things that we should be looking at, that it make men not want to go to seek help. And they will be going around, going to and in the last stage, while he's no longer working for himself, now being pushed by the family on the wheelchair, he don't have energy and then must be admitted to the hospital. So if we can trying to call lifestyle of Imbizo with these men, educating them as a room, and in the room only men. So we talk about these issues and how can we better our services so they can be accommodating them. I know some of you guys know South Africa. We are privileged some of the services. We're having males clinic, we're having youth clinic, but how can we educate them to say they can go to those services? And the services, if are happening, should be only focusing on STIs and preventing the children, not integrating. You see, so if it's an integration, it can be easy to those healthcare facility. And we work with Jeremiah, we work with Amon, we worked with Jerry. Jerry, I know him from Bangkok. So we work together on this, and we try to hosting those individuals to talk about the better funding so we can do these activities that should be happening, educating, having Indaba together, and we host it, we travel to South to whole Africa, even wherever it's supposed to be, and we preach this to say, man, let's embark, because you see Jeremiah, what he was now presenting about the higher men not attending the healthcare facility, all of those things. But how can we do better? How can we break the stigma? Stigma will always be there, but we need a strategy. Thank you very much.
Thanks so much, Goodman. I now have some questions for the full panel, and I'm actually going to combine questions from a few of our participants who've asked about similar topics, thinking now about action and solutions and interventions maybe that leverage these masculinity concepts. So from Bruce Karinga at the Makerere Lung Institute asks, what do the speakers particularly recommend, and do you have any examples to share with us? From Ebuka Ugwu at the Zankli Research Center in Nigeria, a question about, do you have any suggestions on how TB programs can engage adolescent boys and young men as they're increasingly missing out on care in some African contexts. And also a question from Ellen Mitchell at the Institute for Tropical Medicine in Antwerp, asking if you could comment on the role of faith communities in structuring or restructuring African masculinities. Could I maybe ask Jeremiah or Jerry to start us off with some ideas about how we respond to these contexts to improve TB care?
All right, so thank you very much. And based on the stigma index study that was conducted in Ghana, it clearly shows the various form of stigma that men incur in accessing care and services. I think that this is very important because if you really want to know the extent to which stigma affects access and availability of services, then we suggest that we need countries to really dive into conducting a stigma index study. This stigma index study should be done in collaboration with the National TB Control Program. To which we need to have a look at it, because these findings from this recommendation will be able to design programs, activities that will tailor towards making sure that the gap missing the TB people, especially men who are being missing in the community, we try as much as possible to find them and also bring them back to treatment. It is very important because in our work in Ghana, what we are doing now is to make sure that we are reaching out to the men in the community. We don't wait for them now to get sick and then when they are in the point of death, rush to the hospital, because men, before we rush them to the hospital, they are very weak, their condition are deteriorated. So what are we doing? We are rather reaching out to them in the community where they stay enough in the club, where they stay enough in areas that is called hard to reach communities. We need to go to those hard to reach communities and inform them about their health and their conditions and also improve them. By creating that knowledge, they are able to also know that their life matters. Their life is very important because if they don't take care of their health, they also put in their family in danger because they will not be there. So it is very important, and that is what currently we are doing. So apart from that, we also done the patient cost survey, which is also very important, so that the recommendations in the patient cost survey has enabled us to advocate for TB to be included in the NHIS. Okay, so now if you have TB, once diagnosed, we automatically roll you on the NHI so that you don't incur other costs in terms of accessing services. We try to eliminate those costs so that men can freely go to health services and get diagnosed and put on treatment as well. So thank you.
Thanks, Jerry. Go ahead, Jeremiah.
Thank you, Catherine, and thank you, Jerry, and my co-panelists. These issues just reflect how complex the issues we're dealing with are. We have to look at healthcare services. Are they responsive to the needs of men and young people? I think young people tend to not. Okay, I'll continue. Young people tend to be disconnected from healthcare services. But I think young people in Africa, we probably miss them because a lot of them are in the transition phase. They do not have resources and they have to explain about their healthcare access to probably their parents, and they have to find money, they have to travel. At the same time, they are looking like these are strong people. These are people who are trying to still grow and assert themselves. So there are people in transition. But young people, we need to especially work towards attending to their specific needs, at the same time working with healthcare services in order to make sure that they respond to men. I'll just give an example of that I usually give of, my experience many years ago when I took my own son to a clinic, and my wife was not there. My wife had gone to work, and I took my 2-year son in. And my experience with the nurses there, I was sitting on the bench, and the nurses just looked at me and said, "What are fathers doing here in the children's clinic? Where is the mother?" They knew my wife, and they were saying, where is she today? So it was almost like I had done something wrong, and she couldn't come and present with the child. But again, these are experiences that men deal with, and the stigma that the Goodman has been talking about. In terms of faith, religion is really, really strong on the African continent. And when you look at it, it can go anyway. It depends on who the leadership are, what is it that they are working on at that particular moment, what is it they are driving, how sensitized are they to this emerging body of critical conversations. I think for us to address the issue of men and health in Africa really requires us to co-develop the discipline of social sciences and just, engage in issues and be more open-minded. But it's possible that some religions tend to adopt a more maybe a traditional based stance, whereas others may be more open. So again, it depends on what dimension they are working from, but certainly they are a key factor, and it is a space that needs to be involved in order to ensure that men do not use or more like fall into pursuing behaviors that are also damaging for their health, just because they're trying to project themselves in ways that align with what is being pushed by their denomination. So it is an important space to focus on as well. Thank you.
Thank you, Jeremiah. Unfortunately, we're nearing the end of our webinar. So I'm going to have to close the Q&A session now, but thank you to all the participants who submitted questions, to our speakers for their responses. And if there are any questions we weren't able to address, we'll try to do so and send responses following the session. Just before we close, I'd like to ask each of our speakers to share their main takeaway message from today's session. I'm just going to give each of you a brief 30 seconds to make a statement, and we'll go through in reverse order of the presentation. So if I could start with Jerry, what's your 30-second take-home message for today? You're on mute.
All right, so thank you very much. So in one of my recommendations, I made mention of adopting a gendered approach to TB programming. So it has to be a deliberate attempt by the TB program to make sure that we are not leaving the men behind. We are not leaving no one behind. We must make sure that the program is designed such a way that it is very culturally sensitive to men, that men feel that they have their responsibility to take care of themselves. So they don't need to wait for longer time for them to be able to rush to the hospital. So we have to put men at the center. By so doing, it doesn't mean that we are not also engaging the female. Everybody must also come together, but we need to put interventions that is more culturally sensitive to men, that will accept men to be at the facility without any discrimination, without a fear of being tagged at the facility, health facilities as well. So basically, that's my take home. Thank you very much, Patrick.
Thanks, Jeremiah. Jeremiah, on to you, 30 seconds.
Thank you, Catherine. I think just listening to my co-panelists from Goodman and his experiences, and to Amon and the theorizing, and to Jerry, I think there's a thread that you know, it is an exciting space and time to be, but we need to do more. We need to engaging men is very complex. It's an intersectional space, and there's need for more work in terms of continuing to understand how men's vulnerabilities are created in the different spaces across the continent. And I will always say this: the role of social sciences needs to be elevated more, especially within the health space, rather than treat health more as a biomedical space. So I really would urge that to continue. Thank you.
Thanks, Jeremiah. Eamon, on to you, 30 seconds. Just take yourself off mute, please.
Yes, sure. It is to say that, yes, we have a body of knowledge around gender and health, and that within that, we need to be deliberate on masculinities, the focus on masculinities, particularly to enable men to understand that it is possible for you to be vulnerable, to be healthy, and it is also okay for you to seek medical care. That, you know, being a man is not that natural and etc. It is something that is socially constituted. That is important.
Fantastic, thank you. And on to you, Goodman.
Thank you, Chair. But you know, Chair, you're not right. You start with me first. Now I must be again the last one too. They take it all now, my words, but thank you very much for this opportunity. I hope we will having this platform again and to share our way forward, what we should be done. The takeaway message, I thought on my side, it's only in South Africa, we're having an issue with the men running away from healthcare facility, not seeking help. So I learned to other countries also to have a similar problem, but what are we going to do? Let's go back to the drawing board. In the war room, we discuss this and we come with a good point that we can embark together, because solidarity is power. Thank you very much.
Thank you, Goodman. And lest I be unfair to you, I will add my 30-second thought, which is that I've been really struck by the consistency of themes that all of our speakers have shared today, whether they were speaking from the context of personal experience, gender theory, social science research, community and practice. We see really clear evidence of the way that masculinities affect men when it comes to their risk of TB and their access or barriers to seeking care. So that really strikes me, as well as the opportunity to move forward together and find ways to overcome those barriers in partnership with men, women, and persons of all genders across these different contexts. I'm going to close our session now. I would like to thank our speakers for sharing their valuable experience and knowledge and insights. I would also like to thank the individuals who played key roles in preparing and coordinating this event. So this is Beata Ringwald, Joy Gilroy, Tagreed El-Haj, and Kerry Millington, as well as Thomas Cullen, who provided our IT support. Finally, I'd like to thank all of our participants who had joined us today. Thank you all very much for being here and for your work and your involvement. The webinar is now closed.